Now, Dr. Philippe Koch will present systematic gas injection at the end of epiretinal membrane removal to reduce the surgical trauma induced during surgery.
Yes, thank you. So, as an introduction, peeling the ILM seems necessary to avoid epiretinal membrane recurrences, as said Antonio, and as I already said. But it's traumatizing the ganglion cell bundles and the retina, leading sometimes to decreased visual acuity, leading sometimes to a thickening of the retina postoperatively. And few studies report its creation of macular holes following ILM peeling, particularly in CME ILM peeling, CME epiretinal membranes, cystoid macular edema epiretinal membranes, and in vitromacular tractions. I will show you a study I performed between 2007 and 2011 prospectively, and we followed our patients up to 4 years after surgery. And the idea was at that time to use gas, SF6 gas, 0.4 cc of pure SF6 gas, injected at the end of surgery, as a massage, as a tamponade to try to reduce the trauma induced during surgery. So we tried to inject gas tamponade to counteract the perioperative elongation of the retinal fibers by massaging the macular area in the first postoperative days. So we were asking patients to observe a face-down positioning for 10 minutes per hour during days for 7 days. So it was an ambispective, mostly prospective study, but we lost for three patients, so we introduced 3 patients retrospectively, and it was performed by myself and Jacques Libert, who was my former head of department, and the inclusion criteria were idiopathic epiretinal membranes and best corrected visual acuity in logMAR between 0.5 and 0.2, meaning in decimal between 0.3 and 0.6. And we had mostly pseudophakic patients or rarely young patients around 40 years old who, of course, do not have any sign of cataract. Clinical evaluation was performed with best corrected visual acuity and OCT before and up to 4 years after surgery, but particularly at 1, 3, 6, and 1 year after surgery. And we performed the systematic ILM peeling using Brian Peel, Brian Luigi. We had 2 groups, a control group without gas, which we'll say was a normal group, and a study group with 0.4 cc of pure SF6 gas. And we asked the patient to observe a face-down positioning for 10 minutes per hour during the days, and this gas bubble remained for approximately 7 days after surgery, as an average. So first of all, as you can see here, it is without gas group, the control group, and the study group with gas. Preoperatively, the groups were very comparable with a visual acuity of 0.4 in logMAR and standard deviation which were very comparable. But after surgery, you can see here that in the gas group, visual acuity was definitely better than in the control group, first of all. And secondly, as you can see here, standard deviation was almost the same in the gas group, whereas in the control group, standard deviation after surgery raised a lot. And I think this standard deviation is one sign, among others, of trauma induced during surgery. So because we had comparable groups preoperatively, we could we could measure the number of lines gained after surgery. And 1 year after surgery, in the control group without gas, our patients gained approximately 1.4 lines, whereas in the group with gas, it was 3.8 lines. Of course, it was statistically significant. Very briefly, we examined the distribution of idiopathic epiretinal membranes in our group. So first of all, we had diffuse epiretinal membranes, cystoid macular edema, CME epiretinal membranes, pseudo-hole and lamellar hole, we put it in the same group because we consider that pseudo-hole and lamellar hole are probably of the same origin. And we included vitreomacular traction because it could be in macular hole studies or in epiretinal membrane too. And in number of lines gained, we'll say that the diffuse group was statistically significant, and we had a tendency for cystoid macular edema to be significant too. But in the PLH, in the pseudolamellar hole group, there was absolutely no statistically significant result, meaning that, of course, and it has been shown in other studies, operating pseudo-holes and lamellar holes is sometimes tricky, and I'm still not convinced that this kind of patients need to be operated or not. Thereafter, we measured the ratio of postoperative over preoperative macular thickness by OCT, and it means that with a ratio of 1, you didn't change the thickness of the retina. So if you reduced it, it means that you slightly reduce the thickness of your retina. And in the gas group, reduction of the thickness was better than in the control group. But sometimes reduction of the thickness is also associated to a thinning of the retina, and we need to be very careful with that. So just to show exactly the same results, in the diffuse group we had the same results, in the CME group we had a tendency, and in the PLH group there was absolutely no sign about that. So the next question is gas injection associated to better final macular contour? So we asked 2 surgeons to check on OCTs and to say if the macular contour by OCT was normal or abnormal. And as you can see here, in the control group without gas, we had mostly abnormal contours, whereas in the gas group we had frequently 1 year after surgery an almost normal macular shape. The next question was to know when to operate with gas. So we took 2 kinds of patients. Patients with a bad preoperative visual acuity, which mean in decimal between 0.2 and 0.3, and people with a good preoperative visual acuity, which means in decimal between 0.6 and 0.7 visual acuity. And as you can see here, the bad visual acuity group is gaining more lines, and it has already been described in other studies because, of course, we are coming from far away, and we can raise even better if our visual acuity is very bad. But when we focus on the next question, meaning what is the final visual acuity, definitely in the bad group, the patients are not recovering totally, whereas in the good group, our patients are more prone to recover. In the bad group, our patients were recovering 0.1 logMAR visual acuity, and in the good group, our patients were even higher. And 4 years later, because we could say, okay, at 1 year, we just speed the recovery, but perhaps after that, in a few years later, we will have the same results finally. But 4 years later, we compared our results, and in the gas group and the control group, we had almost the same results. Of course, some patients lost vision, but it was more than 70 years old patient as an average. So in conclusion, systematic gas injection at the end of surgery is acting against trauma induced during peeling. It gives us a better visual acuity, better results for gain of lines, better ratio of post-operative over perioperative macular thickness. We have more normalized aspect. And I will say that I feel more comfortable operating patients earlier. And of course, these results are consistent with time. But it is, of course, small groups. Nowadays, I already operated more than 1,000 patients with gas. in an observational study. And few colleagues are nowadays routinely injecting gas or air with similar effects. So the next question to answer would be, is it better to inject gas or air? And I don't have, of course, any answer. Thank you very much for your attention.
Thank you, Philip. Any question from the floor?
I'm Eva from Sweden, and I have a question. Why do you use a pure gas bubble, 0.4 milliliters, instead of doing an air-gas exchange or at the end?
Quicker.
Okay.
I just use 0.4 cca of gas at the end of surgery, and the day after it's filling approximately 40% of the vitreous cavity the day after, approximately.
Okay. Right.
Meaning that the day after I'm still able to see the macular area.
Philip, we have done a similar study, but not prospective one as yours. So your results are much more reliable, of course, but we have done a retrospective study, and I was always giving mostly air at the end of the surgery just to have the effect of mechanical ironing of the fovea. And we just compared the results with air and without air group, so we couldn't get any difference between the visual results and the anatomical results. Do you think this is because of the gas for a long time, or because this is because of the retrospective nature of the study?
I don't think it's due to the gas effect, because one friend of mine from Grenoble in France, Pierre Albinet, is doing exactly the same since I presented my results, and he's using air. I will say that I think retrospectively it is not a good way to examine this, because in fact everybody, I think, or most of us, will inject some air or gas at the end of surgery when something goes wrong. You know, when you see that you're pulling on your retina when you're removing your ILM, naturally most of people will inject something because they say, oh, it was not so good. So I think that retrospectively it's very hard, and that's why we were very difficult with our patients. We selected 61 patients over 300 patients at the beginning, removing a lot of patients. Some sign of cataract out, some clues of thrombosis out. No, you don't have diabetes, but you're taking glucophage, okay, out. Etc., etc., etc. You have some diabetic patients in your family, out, etc., etc., etc. So it was we were very strong with our patients. But nowadays, with almost 1,000 patients with just gas at that time, always gas, I will say that these results are very consistent. During this study, we just had one patient who did not recover a better visual acuity over 30 in the group of gas, but I would say it's more a ratio of 2 or 3 patients over 30 nowadays, but definitely we do not lose vision, I will say. The only cases that are tricky are uveitis patients, diabetic patients, etc., because we have a thickening of the epiretinal membrane.
And one more question. Do you think the gas is just making it earlier, the changes earlier, or, I mean, with time, do you think both groups will become together? The tendency, is it like that, or the difference will be just the same with time? What do you think about that?
I think there is a tendency in my statistics to say that it's coming quicker, but not so much. And this is why I finish with the idea of putting air, because Pierre Albinet from Grenoble is doing a lot of ILM peeling with air at the end of surgery, and he definitely observe a quicker response with air. So perhaps air is even better, okay? Because we have oxygen, etc., etc. That is not bad for the retina somewhere. So perhaps it's a better idea, but actually I just used SF6, pure SF6, and I'll
No,
try to...
I just meant, do you think the group without gas will catch the group with gas with time? I mean, visual acuity respect and foveal contour respect?
No, it was one of our questions, and that's why we wanted to follow our patients up to 4 years after surgery to ensure that there was no, finally, no recovery of the control group, and it was not the case.
Thank you. Antonio?
Yeah, very nice talk, Philippe. You know, I have been using air fluid exchange in all my cases of macular Packard surgery from maybe 10 years. Like Steve Charles, when we started to do small gauge surgery, suggested that if you leave air in the vitreous cavity, there is less risk of leakage from the unsutured holes, 23 or 25. So the reason why I do air fluid exchange since then, it's my routine, is because I think that you have less risk of hypotony and leakage if you leave the eye with air compared to fluid. And your observation is very nice. I didn't do for this reason especially, but I always do air fluid exchange at the end of the case.
Okay.
Thank you. Any other question? Please.
Yeah, I would like to ask if you do positioning the patient, and do you think it matters?
Yeah, most of my patients, for facility reasons, are operated with a local anesthesia. So just after surgery, they are taking a coffee, and before they leave the clinic, so let's say 30 minutes after surgery, we ask them to do their first face-down positioning for 10 minutes. So the nurse just checks that everything is done properly, and then the patient can leave away. And I think it's the first, as Sengul mentioned, it is an ironing procedure. You know, you are removing a membrane that is pulling on your tissue, and after that you are just ironing your tissue. And I think that the quicker we do it is probably the better. Theoretically, I didn't examine this, but I think that if we do it in the next minutes, the first 30 minutes, it should be better than waiting the day after and things like that.
You still ask the patient to do face down after home, or 1 or 2 weeks afterwards, because
no.
the gas bubble is in the
just
eye.
when there is gas, so approximately it's remaining for 1 week, and just during days, and it's just 10 minutes per hour, because first of all, I'll say that I would be concerned about this pressure exerted on the macular area with a small gas bubble, because we know that if you are bleeding from your finger, you just compress here, okay? And that's nice. But if you continue like that for a few minutes or a few hours, I don't know what will happen, but perhaps we will get a necrosis, and perhaps it will not be as good as we could imagine. So if we consider that a heart attack is acceptable for the first 3 minutes, it's why I consider to say to my patients 10 minutes is good enough, because I know they are not doing 10 minutes, but perhaps 5 or 6 minutes, because it's boring and etc. etc. But results are not so bad, I'll say.
Thank you.
Thank you.
Okay. Any other question? I think you're also advising patients avoiding from lay down positioning, probably. Yeah.
Yeah.
Okay. Jerry?
Since we have a room of people interested in the vitreoretinal interface and these diseases that were very nicely covered by this symposium, I'd like to make a pitch for increasing the precision of the terminology that we use. Epimacular or epiretinal membrane is imprecise. What we're actually dealing with are premacular membranes, and so the acronym ERM should be replaced with PMM, a pre-macular membrane, as opposed to an epiretinal membrane. Furthermore, the disease is not ERM. The disease is macular pucker. And these membranes are very different from people who have macular pucker and people who have macular holes and people with diabetic macular edema, as we heard earlier. So we have to improve our terminology and break down our groups into pure groups based upon our thinking of the etiology and what we find histopathologically. And I think that your study would be very much strengthened if you did subgroup analysis. Now, I know the numbers get very small, but the biggest problem in my hands is the group of patients with a premacular membrane and macular pucker. Those are the people that often have swelling postoperatively after a perfect operation with no hemorrhages and the membrane came off nicely, but the macula is still thickened. So if you can show that in that subgroup of individuals, including a gas bubble decreases the thickness, that would be a very helpful thing for all of us to improve the patient's outcomes. And I saw that you used a ratio. Did you use a ratio as well as the absolute thickness of pre-op versus post-op? Why did you end up doing the ratio? I'm curious to know.
We tried to find the foveal area, and we just measured at the foveolar place, let's say it like that, measuring the foveolar area, foveolar thickness, preoperatively and postoperatively.
But if you use the absolute numbers, were the results the same?
I don't know, we didn't do it, but we are actually examining these 1,000 patients because it's an observational prospective study somewhere, and we are trying to re-examine everything. We're trying to understand because in this group of patients, we have diabetic patients, we have every kind of pathologies, and we will try to figure out some statistical informations, but let's say that my assistants are a bit working a lot, let's say like that. But definitely you are true to say that we need to get a good terminology, but in my mind, I know most of people are nowadays using macular pucker, but I'm not very confident with macular pucker because in the 1980s, some surgeons used macular pucker for epiretinal membranes with a hole in the periphery or epiretinal membrane following retinal detachment. And in these specific cases, I think it's a totally different case. I will put this case in a sort of PVR group, you know.
You're absolutely right.
I totally agree with you that our terminology is not good at all, but we should sit down and think how to figure out a good terminology to publish something and say, this is what we need to use as a standard for defining our pathologies.
Correct, and linked to pathophysiology, or as best as we understand pathophysiology, including anomalous posterior vitreous detachment and vitreoschisis, which I think is another aspect that needs to be looked at as a subgroup analysis, presence or absence of vitreoschisis. Thank you very much.
Thank you.
Thank you, Jerry, for especially warning us about the terminology. And I think there are many unknown things still considering the premacular membranes, because after surgery, some of them are, the foveal contour is not normal, but you have the full vision, and some of them are just normal, get normal contour, but the vision stays, you know, still low. So we should, I think, do some more studies on these aspects if they have any other considerations. Thank you. Would you like to conclude the session?
Yes, please. So I will just say a few words to try to conclude this session. First of all, ILM peeling is preferable to posterior yelloid removal to try to avoid recurrences due to ILM contraction after surgery, and it allows the best recovery as possible. However, peeling the ILM is traumatizing the underlying ganglion cell bundles, but there is some ways to reduce the trauma we induce, as we saw today, and many different pathologies could benefit from it, either idiopathic macular pucker or epiretinal membranes, secondary epiretinal membranes, primary macular holes, or complex or recurrent macular holes, as an example. As an example, the classic and inverted flap technique presented by Zofia allowed great enhancement in macular hole closure, and I trust her because I'm doing it routinely nowadays. Particularly, the temporal inverted flap technique would be really interesting by avoiding to peel the ILM in the maculopapillary bundle. Of course, the free flap technique is interesting in complex situations, but would become another interesting procedure to avoid peeling the ILM over the macular area. Some studies even dig further inside OCT details to try to predict surgical outcomes. In their article, Seidel et al. Showed that remnants of ILM are still present on the retinal surface in almost 50% of cases. And it is extremely important because it could explain some recurrences that some groups worldwide are observing in their studies. They demonstrated two conditions to be associated with a persistent ILM. First one is a thickening of the epiretinal membrane, and second one is when the epiretinal membrane is elevated over the retinal surface. In such cases, you should take again your dye, your vital dye, to color again your retina, because frequently you will find a second membrane. But one weakness of this study is that the team was staining his retina using ICG, and I would recommend to use Bryant Blue G, because of course it's not as good to color the membranes, but with Bryant Blue G you are coloring astrocytes, and thus you are probably not missing membranes. Shields and all found that better postoperative visual acuity was associated with the presence of preoperative retinal contraction, like here, and of a lower preoperative maximal retinal thickness. So in such cases, with a retinal contraction and a lower maximal retinal thickness, your patient should recover a better visual acuity. So it means somewhere that we don't need to wait a too long time. In the same way, they showed that preoperative foveal ellipsoid zone attenuation, like here, as you can see, we have an attenuation of ellipsoid area, or even ellipsoid absence. In such cases, also, your patient will recover properly. But as they said in their article, pseudo-holes are not associated with visual acuity enhancement. So, as a conclusion, be aware of possible trauma when peeling the ILM. Particularly be careful with light toxicity. I'm working with the slit lamp. It's an old technique somewhere, but it gives me precision when I'm operating my patients. And I will say that I'm forgetting light toxicity because I'm as far as possible from my eye. Be careful with dye toxicity, with ICG, with any other dye. And as we already said, of course, please start temporally to the macula to try to induce as least as possible trauma. If you want, if you have the possibility, please try the flap technique in macular hole surgery, or of course the free technique. And in some cases, try to inject some gas or some air at the end of epiretinal membrane peelings. Of course, please continue to be aware of this phenomenon and try to recognize early prognostic signs to operate early if possible and if needed your patients. Thank you very much for your attention.